morning, John. How are you today?
Morning, Kathy. Great. How are you?
Good, good. Hey, viewers, welcome to our series on substance use treatment. When you finish this series, you're going to have a better understanding of the benefits of a medical model treatment program. We're beginning this journey with 5 digital workshops, and we'll continue to add those additional sessions from input from you. Just let us know what you would like to see, and we'll be happy to take those for you. So there's a lot to running a successful treatment program, and we can't stress enough how important it is to have everyone in your facility on the same page. Mindsets like how you and your team of professionals view addiction, what type of therapies to use in your facility, and even how you'll approach and support families living with loved ones with substance use disorders. They have to be similar so that patients get a unified treatment program, regardless of which therapist, family coordinator, or other staff member a patient works with. My name is Catherine Hendrick, and I'm on staff here at Addiction Treatment Strategies. Now, ATS is located in Edwardsville, Illinois, and we're just outside of St. Louis, right across the river. We're a 6-month intensive outpatient medical detoxification and stabilization treatment program. That's a lot, we know, all in one sentence, but we're a therapeutically based, medically assisted program, which provides an extremely effective treatment program for our patients afflicted with substance use disorders. This digital workshop is going to be led by John Crum, and John is the founder of Addiction Treatment Strategies. And today we decided to do a workshop that'll give you some insight into the form of behavioral treatment that we choose to use here at ATS. So John, I'll let you go ahead and get started.
Okay. Yeah, I think everybody really needs to know, Kathy, that this grant is a component that Southern Illinois Health Foundation approached HRSA, and it's a part of the Rural Centers Opiate Response Program. So specifically, this is for rural counties who may not have access to opiate responses. So SIF applied for the grant, and this is a product of that. So we have about 9 series, as you mentioned, 9 talks in the series, seminars. And the one we're going to do today is definitely on cognitive behavior therapy. And what I'm going to do is go through some of basically the history and paint a broad stroke of what cognitive behavior therapy is. And then we'll get to some specifics, more of a fine stroke of specifics of addiction treatment, CBT. And then we'll finish with some of the principles of what an addiction treatment model is relative to CBT. Okay, so cognitive behavior therapy is another form of talk therapy that basically explores and uses the dynamic interaction between thoughts, emotions, and behavior. I think the important statement there is the dynamic process in terms of we don't just focus on one thing and your thoughts and feelings will change. So for the most important theory is that when a person changes their thoughts, they will also change their emotions and behavior. So CBT is one of the most research-based treatment programs in a lot of mental health centers only because it works. Now, Aaron Beck in 1963, who's probably known as the father of CBT, stated, "A generic cognitive model proposes that all psychological problems, regardless of their etiology, results in problems in thinking." Now, that's 1963. In 64, he went on to say, "In CBT, identifying and correcting these biases and distorted errors in thinking are key to reducing client stress." And I think if we get back to what Beck said in 63, that is the essence of cognitive behavior therapy. So what exactly is it? Well, there are research-based outcomes with clinical measures that demonstrate the anticipated changes in patient symptoms. So what this says is that there have been a lot of research, and CBT is by far the most commonly researched type of treatment, only because it has effective outcomes. It's used worldwide in various forms with various derivations. Old people, young people, it's used in Sweden, it's used in Italy, it's used all over. CBT is a psychosocial intervention strategy that was originally aimed to reduce symptoms of depression and anxiety disorders, in addition to other mental health disorders. Oops. Research has shown CBT is one of the most effective means of treatment for substance use disorders, specifically as it relates to co-occurring mental health disorders.
John, can I ask you a question real fast?
Sure.
When you founded ATS, was there any doubt in your mind that you were going to use a CBT type therapy with your patients?
No, not really. In terms of CBT has been around, since back in the 60s. CBT was an evolution from obviously blending, and we'll get into that in a minute, blending of cognition and behavioral therapy. I was trained in the 60s. There was a lot of behavioral intervention strategies, and we were just really getting out from under everything that was total behavioral and moving in the direction of CBT. So I saw it as something that had potential for the future back in the 60s.
Okay, thank you.
So I'm going to look a little bit, I think, at the history behind the psychological theory. Until the 80s, when the concept was first used relating to mental health disorders, individuals, patients were treated for just the primary symptoms of disorder. We didn't have anything in terms along the concept of co-occurring disorders. So whatever a patient presented with was what they got treated. I think this points out very important historical factors as it relates to how treatment should be provided and who should be responsible for providing this treatment. So if you think evolution, I think it's really helpful to look at where did CBT come from, because you're going to be able to trace, when we get finished with this, you're going to be able to trace some of the roots all the way back to Freud. And probably what we're doing today in 2024 at some point is going to be found to say, well, if you guys had only known this, you would have done it better or differently. So I think that's coming. Okay, so CBT has been linked and studied in relation to numerous religions and philosophies. It goes all the way back to Taoism, Christianity, and Judaism. We're talking 3rd, 4th century BC. The most prominent historical roots are traced to the philosophy of Stoicism. And when people start talking about CBT, definitely the Greek philosopher Epictetus believed logic could be used to identify and discard false beliefs that lead to emotions. That is Stoicism. Logic trumps emotions. So this belief has led to the concept of cognitive distortions that led to depression and anxiety, and that comes following Stoicism. That's what comes next. So here's some people that I thought were important to look at in terms of even the roots of CBT. From the behavioral side, there's Pavlov, and almost everybody who's taken a psych class knows that Pavlov was the one who was studying dogs' responses, salivation to dogs' responses. He observed that when he fed his dog, the dog salivated. He also later observed that when he walked down the hall with the feeding cart, the dog starts to salivate. And then Pavlov was concerned if he could actually get the dog to salivate to a bell. That is the beginning of classical conditioning. That's what Pavlov did back then, and that definitely has some behavioral roots from then on. So that was back in 1897. The next person I think was a gentleman who found that it was easier to condition extroverts, or it was harder to condition extroverts versus introverts to shape behavior. So he moved from Pavlov to people and started shaping behavior. And then Skinner, B.F. Skinner, who was into operant conditioning, and he was known as or referred to as the radical behavior. And he's the one who developed the Skinner box and worked an awful lot with rats and mice to get them to move and shape their behavior. Some of you may know the term or the name Nathan Azrin. He was at Anna State Hospital in the 60s, and I was at Anna State Hospital in the 60s. I knew who he was. I didn't know how important he was to the development of cognitive behavior therapy, as he had a large behavioral lab there, and he worked a great deal with, at that time, what we would call today developmental disabilities. At that time, it was called mental retardation. He had an awful lot of students come from all over the country to study and work with him because he was a student of Skinner's. On the other side, we have the development of cognitive therapy, which goes from Freud to Adler to Lowe to Albert Ellis, and then Aaron Beck. And I think he's the one that Beck said he believed that all thoughts were unconscious and some thinking was emotional. So he was definitely the originator of cognitive therapy. A little bit of background on the state of Illinois. In the 60s, it was divided into 3 departments, as best I can remember. There was a Department of Mental Health, there was a Department of Developmental Disabilities, and there was a Department of Substance Abuse. So what this means is when a patient presented with a problem, they were treated by one of these 2 departments. And in reality, what was happening, as I was trained, as I mentioned earlier, I was trained in the Diagnostic Statistical Manual 2, where we had things basically in four large categories. That was psychoses, neuroses, personality disorders, and transit situational problems. So you had to fall in one of those two categories in order to be treated. And if you didn't fall into one of those two categories, then basically those were the people that we said fell through the cracks. Most of the people today that we're treating in mental health issues, all of them have co-occurring disorders, and most of them do. So back in the 60s, you wouldn't have known which population or which service provider was responsible for that treatment.
Right. Nowadays, you wouldn't even consider something not being having another co-occurring disorder.
Yeah, that part's true. And I think what that tells you is the Department of Mental Health had a philosophy on how to treat people. Department of Developmental Disabilities had a philosophy as well. Substance abuse had a philosophy. So what you would see is three different treatment approaches to an individual person who may be manifesting multiple symptoms, co-occurring symptoms. Mm-hmm. So in any developmental process, the administration branch doesn't always comprehend what the clinical branch is doing because patients aren't pure. The DD population, primarily in the 60s, was being served by behavioral therapy and medications. The MI population was being served by some type of cognitive therapy and medications. And the substance abuse population was being served primarily with a moral approach back then. So the focus of CBT is on challenging or changing cognitive distortions. That's it, how your thoughts, feelings, and behaviors and the resultant behaviors associated with these thoughts. So this then develops into learning and coping strategies to address specific identified areas of discomfort. In our case, we're going to be talking about the factors that relate specifically to addictions. So CBT is problem focused with direct change in behavior related to the diagnosis of the presenting problem. So the operative word, I think, in this is focused on how you think as opposed to how you feel. We encourage people to keep a written journal. We call it a thought journal here. So specifically, what were you thinking just before this occurred? The therapist's role is to help identifying a specific problem that can be articulated in a written plan, key on written, to assist the patient decreasing or eliminating the symptoms that they are feeling. Oftentimes, people like Freud might say, okay, why are you worried about what your mother is thinking about what you're doing? That would be his approach. Freud would say, how does that make you feel? And Beck would say, well, let's look at some previous thoughts that might be causing your problem. That's three different approaches to the same situation. So the strategy is focused on thought distortions that led to dysfunctional behavior as the root of maladaptive behavior. That's really complicated, and that historical interventions strategies for mental health were almost solely dependent on medical interventions, and the use of CBT is relatively new. Thorazine was first used in antipsychotic in 1952, as medical interventions have improved so much, so have psychological strategies. Thought disturbances, we didn't know much about that back in the 50s and 60s, but we had medication that addressed those changes, but we weren't able to do much about treatment. So if these behavior patterns are not changed, they're going to come back again. So consequently, if the thought disturbances or distortions are challenged and new coping strategies are introduced, then these changes in thinking and emotional responses are thought to believe or led to believe to more functional behaviors. Let's take that apart just for a minute here. So we have medications, okay? And that's okay. We have medications that we were using for lots of people, but we didn't have much good intervention, whether it was cognitive or behavioral intervention. So it was only with the blending of, if you will, medications with either a thought disturbance or emotional disturbance that we begin to evolve into where it is that we are right now. So now we can switch. So the theory behind CBT is how we think influences how we feel. That sounds relatively simple. How we feel then influences how we behave. How we behave influences how we live our lives and the choices we make. That's something that Aaron Beck would certainly believe to be true. So the next slide, there's an activating event in our lives, which then we develop a belief from that event because it's stored in memory. Then we live the consequences from that belief. We have that in the next slide. I think it's the next slide. Yeah, okay. Cognitive behavior therapy is a treatment option for people with a mental illness. It's an evidence-based treatment that focuses on the relationship between thoughts, feelings, and behavior. And I think what I want to say about this particular slide is that not every patient can benefit from cognitive behavior therapy. Those people who have a difficult time separating thoughts and feelings and may have limited introspective skills are going to have to be trained on how to do cognitive behavior therapy before they actually get involved in cognitive behavior therapy. So it may take some time to develop and teach your patient the skills on how to do CBT before you start using the practice.
I'm going to go back one slide for just a minute.
Right.
With this ABC, can you go ahead and give us an example of that? You know, something that might be an activating event, and then that belief and the consequence that comes from it.
Sure. There may be something along the lines of you got a bad evaluation from your boss, and your boss said some things, or you believe you got a bad evaluation from your boss, and you got upset, and you came home and you were angry at your spouse, or you started drinking in that particular event. So the activating event would be your perception of what that evaluation meant. That could also then lead to the belief that somehow or another my boss is trying to fire me, or I feel inadequate. I'm not as good as he thinks I am. And then the consequence of that, but it could be that I'm going to start drinking. To fix that, I'm going to assuage some of those fears and doubts, because now I can drink and it will go away.
Good, thank you.
Okay, so what happens during a CBT session? Negative or inaccurate thoughts are challenged and restated in logical terms, kind of like we just did in terms of if you got a bad evaluation from your boss and you got upset about that evaluation, then the therapist would take that apart and say, let's look at some of the options that are available to you in terms of what does a bad evaluation mean? How do you know it's bad? What are the operational definitions that determine whether it's bad? So your emotional perception in terms of if you're anticipating getting a large raise and the boss said, I'm sorry, we're only going to give you a 10% raise, that may have upset you. So some of the questions that you might even ask with regards to that in the therapeutic session is, well, what about that? Can we break down and look at some logical steps in terms of what was your treatment plan, or what was your plan at work, if you will? What was your plan that said, how many goals did you have to achieve? Did you achieve those goals? Do you think your boss was mad, or are you disappointed in yourself? What type of position do you hold in that particular company that says, are you a president? Are you a vice president? Are you still doing okay? So it's taking apart some of the feelings that people have as a result of basically their history of their negative thought processes that may have played a part in this.
You know, I notice this a lot with our patients, John, in social situations, you know, as well. You know, somebody walks into a room full of people and the first person that they come across doesn't speak to them, and automatically they go into a kind of an isolation mode. You know, nobody likes me. I'm not comfortable here. And we see that happen all the time, and breaking that down for our clients seems to be extremely helpful to them.
Well, we look at that in terms of, Kathy, when we talk about, we use the concept reframe, rethink, refocus, in terms of reframe what it is that you feel in some logical process. I mean, what could have else happened? I understand that you feel that way, but as we know from previous treatment strategies, people oftentimes in terms of go with the feeling. And a component of, if you will, counseling is to help people feel better about what's happening, which I think is considerably different than in cognitive behavior therapy. We're trying to get them to accept the fact and recognize that they have a feeling, but this is the thought process that we need to take apart so that you can make a better decision. Don't go with the feeling, go with the thought process. And I think when we teach patients to reframe, rethink, refocus, they quickly get into the thinking mode just by saying, how can you reframe what you said? At that point, you're already thinking cognitively. Yeah. So then we can begin to challenge what it was that may be a part of your history, which is causing the problem. How many times before has this happened to you? And we can start to separate that, because that's the essence of treatment. Okay, so what happens during a CBT session is much like what we just went through. They learn to recognize negative thoughts that team up with strong emotions. It's absolutely amazing that in the brain, memory and learning is sitting right next to the amygdala, which is your emotional response. Most strong memories are associated with some type of emotion. So what we have to do is to help the patient identify extreme negative thinking. or in reality, some of this thinking is going to be mixed with feelings anyhow. So part of the reframe, rethink, refocus process in CBT is to get them to separate or split out. I said, how much of this is thinking? How much of this is feeling? So part of that is what we're doing when we're seeing patients is to teach them how to change some of the negative thoughts into positive statements. So a patient is basically on the move being taught how to solve problems. So it's that introspective process. How could I have done this differently? What can I see about my history of emotions, and then switch that. So I think we have it in the next slide, cognitive behavior therapy basics. We have an activating event. We have a belief system, which is history, and we have a consequence, a behavioral consequence of how the activating event was created by the belief system, and then my resultant behavior. So what we have here is a diagram that says, okay, here's the activating experience. This is a problem that may cause the behavior. It could be a feeling, a thought, a memory, or a passing thought. Mm-hmm. Then it leads to a belief system, which is this is an irrational belief about whatever the activating event was, which causes us to respond in a given way, which is the consequence of that belief. This is the upsetting emotional consequence of the activating experience. Plus, this is the good part, the interplay of whatever my belief system. My belief system is at the core of what I believe to be true. This behavior then manifests in us using or drinking in this case. Then you have to come up with some type of disputing in treatment. You have to come up with something that disputes your ABC. This is the evidence, logic, proof, irrational belief, or various options you have explored cognitively to study the activating experience and the belief. And then now we have a new response generated by disputing that, which is the cognition part. As a result of your thinking and dispute, analyze the new responses generated. It would be the opposite of using. What will we be doing an emergency behavior plan? This is new. How are we going to do something different? Okay, this is another example I think we went through before in terms of here's the situation. You're coming home from work after having a bad day. As you walk down the road, you pass a friend, but she walks by and apparently ignores you. My thought about that is she ignored me. They don't like me, or she doesn't like me. My emotional response or my feelings, it's autonomic. I feel low, rejected, sad. I'm upset. My physical conversion reaction may be my stomach cramps. I have low energy. I feel sick. And my action plan may be to go home and avoid her. That's an example of an unhealthy thought. Now, part of your CBT role is to take that apart and look at this situation a little bit differently. And here's our example. Here's a situation. You're coming home from work after having a bad day. You walk down the road, you pass a friend, but she walks by and apparently ignores you. That can be an activating event. The thought may be, she looks preoccupied. I wonder if she is okay. The emotional feelings, I'm concerned for my friend. My physical response is, I don't feel uncomfortable. My action plan may be to phone her and see if she's okay. That's moving to a healthy thought process using CBT.
Such a difference between the two. You know, the one being such an unhealthy response and the one being a healthy response. But you can see where people that come with lots of experiences and that unhealthy thinking go back to that unhealthy thought very easily.
Well, that's all learned behavior. You know, whatever it is that we have a collection of learned behavior that bubbles up not only in memory, but in emotion. And when those two things get combined, sometimes those memories, those learned memories and some of those emotions get complicated because they all kind of get together in the proverbial Pandora's box, where once you open that box of emotions, things come out spontaneously and they're extremely upsetting. So that's the purpose of treatment or counseling, is to help people work through some of that information. So the importance of addressing memory as CBT, I think, is really important from what we're learning about the neurological processes of the brain. So the primary inhibitory function of the prefrontal cortex is to exert some type of inhibitory control, which means think about that differently or stop doing that. In reactions to someone who has an addiction, the prefrontal cortex has been damaged. So that makes it really complicated. So the value of a behavior, which is addiction, takes over the value in the decision-making process for that person. So the process then reinforces memory to engage in this behavior again. this is what we call the development of an addiction. And we'll go to the next slide, Kathy, and I think that's shown right there. This is in the non-addictive brain, the control portion is the prefrontal cortex, which then determines the value of something. That's the red one on the left, the value of something, the saliency, and then the determination to go and get that particular thing, whether it's an ice cream cone or a good positive behavior on something else. And then this then is stored in memory. So the value of something which is controlled by the prefrontal cortex then has the capacity to exert some type of inhibitory control process that determines, can still determine what the value of something is or the behavior, what it is. As you slowly move away from losing control, if you will, which is the essence in reality of addictive behavior, is the prefrontal cortex has been damaged. In this particular case, really what we're talking about is a component of either the limbic system or the cortical system, which are both dopamine pathways. The value of a particular substance or behavior has gotten so large that the inhibitory control process of the prefrontal cortex can no longer control the drive in the limbic system because the memory is in the limbic system and it now has taken over control of what it is, the drive to get that particular substance or behavior. So you can see the differences, really, those are almost neurological representations of what's going on in the addicted versus the non-addicted brain. Consequently, the purpose of treatment is to address what it is that's happened to an addiction so that we can get the person back on the right track. And that's when we start looking at negative automatic thoughts in terms of that influence the control of the brain, and then how we can address that in treatment. So when we have negative automatic thoughts, we usually dwell on data that confirms our conclusions. I think there's a strong correlation between memory and negative automatic thoughts, only because the brain does not necessarily think linearly. We know that the brain fires almost 3 trillion times per second, so lots of things bubble up and accidentally get connected. And a lot of these are related to memory, which then can bounce around in there because the brain reverberates your thoughts and doesn't necessarily in reality have to have a trigger. And that's what composes really a negative automatic thoughts. And so because our brain is automatically looking for information supports our net, we often become stuck in this revolving negative thought process. Did you have a question on that one, Kathy? I know you said something about significant memories are oftentimes stored with some type of emotional connection, which is what we're trying to break up with CBT.
Right. No question.
Okay. So negative thoughts should be considered as hot thoughts. That doesn't necessarily mean that they are something that gets to cognition. Most of us know that when you're driving an automobile, you're not consciously thinking about how much pressure to apply to the accelerator and when exactly to turn. So that's already learned. A negative automatic thought is also a component of something that's been learned, and it may not be connected. Cognition involves some type of a thought process. So in reality, these are guesses. They're not really facts. Our brain returns to what's known as memory. It'll repeatedly offer these negative thoughts time and time again, unless it's challenged. And in that regard, when you have a negative automatic thought, these negative automatic thoughts in reality collect other negative automatic thoughts in your brain, and they become paired in what's called engrams, which are sequential neurological loops. So your negative memory can build and build and build. That's something that we're just learning about from neurological development. That's oftentimes how we get into a negative mindset, and then that negative mindset builds and builds and builds. So the role of identifying negative automatic thoughts, research shows that we're constantly updating our memory tapes. You may or may not be conscious or cognitive of that process, but it certainly occurs given the fact that the brain is indeed firing 3 trillion times per second. So this is automatic. You don't control what the brain does with regards to that. We can influence a sequence of firing, but when you're upset by your thoughts, it will react automatically. So these thoughts keep coming and coming and coming, and that's exactly what's upsetting us, because it's probably being a component of a linked engram already that comes from the amygdala, the emotional storage center of the brain. So I think that's really important to understand, especially when we're talking in addiction. We're talking about cravings and compulsions. Cravings, compulsions, neither of which are cognitive processes. They're already there. Memories are bouncing around, and a craving, retrospectively, could be something much like if you eat breakfast every morning at 6 o'clock, about 5:45, your stomach starts to release a hormone called ghrelin, and ghrelin is the bubbling in the stomach. That wasn't cognitive. It was released because your brain has been trained to feed yourself at 6 o'clock in the morning. So your stomach is anticipating digestive juices being released. So the ghrelin is automatically released. You didn't say at 5:45, turn on my stomach, I'm ready to eat. Addiction works exactly the same way. The brain is already ready. If you've had consistent or chronic use of a substance, and various substances vary by how quickly it takes to get them addicted, how quickly it takes to get addicted, as well as the lethality of that drug, your brain is going to respond to positive reward systems, which means if it feels good, your brain's going to remember it. That's the handicap of working with addiction. At no point in there in the development of this in addiction does the cognitive process say, "Hey, wait, that's a bad choice." It doesn't say that. In fact, it says just the opposite. "Hey, wait, that feels good." So you develop an addiction until things may start to happen complicated for you in terms of, we look at areas of health, legal, vocational, relationship issues. Those four issues, if it's causing an issue for you, sometimes it's health, sometimes it's something else. You need to begin to look at how an addiction was developed, because it was totally subconscious. It doesn't have anything to do with morals. It doesn't have anything to do with cognitively being aware of making poor choices. We're not very good at risk assessments as human beings unless we're hit over the head with a brick bat. So it takes a while to unravel some of this neurological processing that constitutes our thoughts, our feelings, our behaviors. And that's the essence of what we're trying to do in counseling is separate these things so we can take them apart cognitively.
Mm-hmm. And you know, John, that's one of the areas I think sometimes that's hard for our families, as well, because they don't quite understand how the brain goes back to those memories, and it's so automatic, and so they're like, well, why can't they just stop? We don't understand why they just can't stop. And so it takes a lot of training of our families as well for them to understand this process, don't you think?
Oh, I think that's the essence of what makes a patient successful is family involvement. I don't think a person on their own will do a particularly good job, because basically that's someone who's swimming against the tide. I think we have developed our treatment methods today are obviously predicated on a moralistic approach to what's going on, which makes it complicated, because I don't think people who have an addiction are morally flawed because they have an addiction. I mean, I think we have to combine people's, if you will, spiritual and religious beliefs as it relates to what's going on in their life, but separate the medical component. So addiction is the medical component, and oftentimes our parents or our supportive people have a hard time not judging either their spouse or their identified patient, whether it's a child or whatever. It's too easy to judge because the behavior itself is the offensive part. It's not the patient. The patient within the patient is the negative component. And I've seldom met a patient in the last years that I've done this that didn't want to be rid of the addiction.
Right.
So I think we're going to talk about a couple of changes in terms of community reinforcement approach. Is really neat. It's a little bit different than CBT. It's one type of addiction counseling that really is an offshoot of what Nathan Azrin was doing in the 60s at Anna State Hospital. So his approach at that point was what's called token economy. And so in the concept of CRA, the patient and therapist work collaboratively to establish goals and do kind of a functional analysis in terms of what is the purpose that addiction or your substance, say alcohol use, is serving in your family or in your behavior. I'm sorry, specifically your behavior. And in this approach, a behavior change is used that the clinician asks the patient to explore what are the internal experiences and external situations that precede their substance use. Now you can see how this is already a component of CBT. So that's what we look at from CBT. community reinforcement approach is going on at the same time. And then we're going to look at in the CRA, the approach, what are the positives of why you're doing, how is it helping you, which also then goes back to Nathan Azrin, okay, with Sigmund Freud, all those people goes back to that. So that's just another component of CBT is CRA. Okay, in this case, the patient has to learn practical skills to meet their goals, whatever that is, in terms of this is all positive reinforcement. Yeah, they have to practice their communication skills, they have to practice their problem-solving skills, and then they have to look at what's called assertive substance refusal skills. So we train people in CRA how to, let's say they want to go into, right, a particular patient whose goal was to go to Buffalo Wild Wings at the Final Four of NCAA finals. He wanted to go because all his friends were going, but he knew that he couldn't go because he was drinking. He was a person in the military who wasn't doing particularly well with regards to his addiction. So we spent almost 6 months looking at assertive substance refusal skills, so that when he got better and better at learning how to say no, or learning how to go through this particular place, it was Buffalo Wild Wings, he could go in there and have a glass of tea. He could go in there and have a glass of tea with his friends. And when it came to the Final Four, he was able to go with his friends, and because he had been practicing assertive substance refusal skills. So he was extremely highly motivated to be able to do that. He was extremely highly motivated because of his military career to stay sober. He was very good at analyzing when his use patterns were. He kept a daily log. And then we looked at how many times he was able to change some of his refusal skills into learned new coping skills. And then he also, at this particular case, he got his friends involved. So they all knew that he wasn't going to be drinking during the Final Four at the Buffalo Wild Wings. And it was successful.
Good.
Community reinforcement family training. CRAFT is also an offshoot of CRA, which goes back to the behavioral approach, which encourages close significant others to reward the patient when they choose sobriety. So we're going to reward. That's the plan here. When you choose sobriety, you're going to get some type of encouragement from your family. We encourage them to step back and also allow negative consequences when the person uses. So this is definitely a component of a behavioral approach on the CRAFT is. And the goal is to move a person from into treatment using positive reinforcement. Positive if you take if you choose not to use, and positive if you do well. So it's a positive approach that involves family members as well. Go ahead.
Let's look at this third bullet. When you say encourage families to step back and allow negative consequences when the person uses, we hear so often our families say, well, he's just not hit rock bottom. He's not hit rock bottom. He's not having enough negative consequences. But when we look at an addiction, the addiction is an addiction because we continue the use despite the negative consequences. Isn't that true?
Yes. And if the person could realize that, the identified patient could realize that, they would stop. And the problem is that they don't have the capacity to stop. So even though we're rewarding positive behaviors when they do well, which is what we obviously encourage our parents to do, or our patients as well, when they're doing well, we want them to recognize they're doing well. Mm-hmm. Now, what this says really is, this is a little bit different than in terms of community reinforcement is a positive reinforcement. And this is a little bit different than, remember when we had intervention strategies, when a bunch of people got together and reality ganged up on the patient to try to get them into treatment. So what CRAFT is doing is trying to get people to move the person, getting positive reinforcement, one thing after another. So we're trying to identify good things and let the person experience some negative consequences if they don't make good choices.
And John, I love the way when you're working with clients, you're working with families, that you help them to realize the IBCs, or the incremental behavior changes, rather than they're either using or they're not using. Helping them to recognize all the steps along the way and the small changes that are being made.
Well, that's a big part of why we do the parent group. Oftentimes, parents think all they have to do is quit drinking. I said, well, if they could quit drinking, they wouldn't have an addiction. So, and I asked patients and parents, how long have you been drinking? And some of the people obviously have been drinking 30 or 40 years. I said, so you've been drinking 30 or 40 years and you want to stop today? Well, that's probably going to take some steps. Okay, so you have to build that. And while the patient is building that in your dynamics of using CBT, we also have to use some of those same skills with our parents. And so part of the craft approach is to get people moving towards entering treatment. If it can't be on an outpatient basis, we're trying to get them somewhere. So it's positive, positive, keep the patient being positive, keep the parents being positive. So the process is to identify triggers. That seems to be universal in almost every treatment approach. That's also complicated because sometimes there is no apparent trigger in terms of something that sets it off. Maybe an activating event, and maybe at work, it may be something. We can look at that, but given the fact that there's probably 8 gazillion triggers out there, it probably helps to try to say, well, what things can I do when this happens to me, which gets back to the cravings and the compulsions. I need to definitely improve my communication. I think that has a couple of positive spinoffs. When I improve my communication, that helps me be more accountable to another person. I think other person support is extremely important in dealing with our identified patients. I think we need to focus on the positive things they're doing. We call it incremental behavior changes. We have simple things like, did you make your bed today? How many days out of 7 can you make your bed? So we're looking at positive things. That's good. When someone comes in and they're under the influence of various drugs because they've been using for 30 or 40 years, it may take 6 to 12 months for them to get out from under that cloud. I've had a patient here who's in reality, his only substance, the way he defined it, he's, well, I'm only a drinker. And I said, okay, that's fine. He says, but after almost a year and a half in treatment, he said, I can tell you when I first started drinking and I came for treatment, he said, when you started telling me things, it was like tinfoil was over my head. And I knew there was something more, but I was being screened by tinfoil. He said, as it got better and better, he said, I began to see things that I didn't see before because of the positive reinforcement. He said, it was almost like saran wrap. He said, so I moved from tinfoil to saran wrap. I could see and I could almost feel it. He said, it took me almost 18 months to get out from under using an awful lot of positive reinforcement. This particular gentleman worked in the entertainment industry. And he said that he knew because his hours of employment were from like 8 to midnight. So after midnight, everybody on the people he worked with would go out bar hopping. And he said it's really difficult to go against peer pressure and not drink all the time. He said after almost 2 years of getting better, he said, I no longer am triggered by the bars that I go by. He said, but I do know where all the ice cream shops are. So he'd switched from a positive reinforcement. He now uses ice cream. Weight's not a problem yet. So he identified some of the emotional barriers, and his emotional barriers were that he didn't want to be left out by the people with whom he worked. So the principle checklist, these are the principles that Beck has come up with in terms of what CBT is all about. So treatment plans are based on ever-evolving cognitive conceptualization because people grow and change. You can certainly change the way people think. You can change the way they respond. You can change the essence of treatment is to get a new concept about what some of your previous memories were. Trauma is an extremely complicated process, as is addiction. So I think this also requires a sound therapeutic relationship. And what they're saying there is that all patients aren't built to do CBT, and you have to have a trusting relationship with the people with whom you work, because really the therapist is poking and prodding an awful lot of challenging the way people think. We call it supportive discomfort. That means you have to be in a position to support the patient, but together you have to challenge some of their cognitive beliefs. That's a lot like sticking pins in people repeatedly. That's a very painful process for people to look at that and then begin to make changes. I think the best way to do that is have some type of a treatment plan where you're constantly looking at how a person is doing in the written format. I think that's the essence of a written treatment plan, where you can sit down and go over those goals on a weekly basis. And each one of these has to be developed to meet the individual needs of the person. Everybody can come in and we can do CBT on them, but there has to be 2 or 3 specifics that a person have, depending on lots of things, whether they're married, they're not married, cultural background, type of employment, even birth order plays a part in what works well with people with CBT. I think what we have to do all along is what Beck says. You emphasize the positive. That goes all the way back to Nathan Asner as well. It's all positive reinforcement. We have to stress the collaboration and active participation, not just with the patient, but with the patient's family, hopefully. It's also aspirational, value-based, goal-oriented. We're looking to achieve things. We want people to get there have some measurable objectives, and they need to feel good about what they're doing. Is that the end of what it is we're doing here, Kathy?
Well, I think you listed a couple more things here. Just to emphasize with CBT, it initially emphasizes the present.
Right.
It educates our clients. Talk a little bit about it being time sensitive. What do you mean by it's time sensitive?
Well, because everybody is dynamic. What happened on Monday isn't necessarily going to happen again on Wednesday. So I think you have to look at how it is that you treat a person or treat a patient with regard to their memory. What I remember about when I was in sixth grade isn't the same memory that I have today about what was going on in sixth grade. Everybody was bigger and taller and faster, and adults are always bigger than we are back in sixth grade. I can remember, and your memories are formed at those times, and sometimes the evolution of those memories cause a distortion. That's the essence of a cognitive distortion. What it is that you believe to be true, hopefully at 40, is not the same thing that you believe to be true at 20. So part of treatment is looking at some of that time-sensitive material, especially if there was trauma in the past. If you started using it at an early age because you wanted to fit in, you didn't fit in, now you do fit in because you're using. So if you believe that you only fit in because you're using, and we take away that use away from you, then you don't fit in anymore. You don't have a personality, you don't have a peer group. That's extremely challenging. So we can't just pull the plug on people. You have to have something that moves from the transition is treatment, from whatever the pathology is to a healthier lifestyle takes time. So everything that we're doing is time sensitive. Mm-hmm. And I think that gets to why we have structure in terms of what the treatment plan is for. We want people to reach some measurable, achievable goals, some very simple things. Here we do a 16-point checklist: make your bed, 1 sit-up, 1 push-up, journal and exercise on a daily basis. Keep track of that. As self-esteem improves, people find out that they can actually do things, and we're going to teach clients to begin to identify some type of their dysfunctional cognitions, because by definition, they didn't know they were dysfunctional. People don't know where they're dysfunctional until really they get into some type of treatment planning with someone to teach them. This could be it. This could be some of the roots of your discomfort.
And then
the next one obviously is we want all of our patients to keep some type of a written plan. We have written plans that we want them to do. We want our patients to keep some type of a thought journal in terms of what was going on just before this happened to you. Write that down. That's the essence of how we determine some of your hot thoughts, which may be consistent or may be occurring at regular times. We'll see if there's a pattern there. So we want you to do something in writing. So I think a great deal of CBT, the part that people miss, give them some homework to do that you expect them to return something in writing. So CBT in terms of uses a variety of techniques to change the way people think, feel, and behave.
Okay. And I know sitting with you, your phone goes off 24/7. It seems like with text, because it's not necessarily a journal on paper. Your clients a lot of times are sending you a text, all throughout the day.
Well, that's something that we're very fortunate in this day and age of technology. I smile when I think I have people, and I know therapists who work in mental health centers, and they'll see 6 or 8 clients a day, and they're overwhelmed. I say, well, then you're probably either the clients are too complicated for you, or you're not using technology as you can. I don't work 9 to 5. I don't work Monday through Friday. All of my patients have access to me 24/7. And in reality, I believe the reason that they do well is because they are comforted by the fact that if they want something to respond to, sometimes it can't wait with addiction. So oftentimes I may be interrupted for 1 minute or 2 minutes or 3 minutes. Seldom does it enter in a long-term discussion. 1 minute of my time with somebody on a Sunday morning at 2 o'clock may save a whole weekend, or it may get them in a position where you need to go to the hospital now. So it's really not much with the technology that we have now to have effective intervention strategies all along the concept of let's change the way we're thinking, feeling, and behavior about this, because we have core beliefs, and most oftentimes some of the fear that drives people about what's going to happen in the future can be assuaged by a simple phone call or simple text.
Yeah, good. Thank you. All right, John, thank you very much for today's presentation. And we sure hope that all of our viewers enjoyed and we'll get a lot out of this as they really reflect on their practices and in their facilities as well. We wanted to give all of our viewers an opportunity for CEU credit, if that's something that you're looking for. In order to receive that credit for participating, you'll need to complete the following and email it to Carissa Vandenberg Clark. She is the assistant professor for family and community medicine at St. Louis University. We are partnering with Carissa with these digital presentations. And so what we're asking you to do in order to receive that CEU credit is to write a 2-page reflection paper on how your thinking has changed after watching this presentation. You know, what attitudes have changed, what practices might change. Make sure that you're citing evidence from that presentation throughout your reflection paper. But the goal of that reflection paper is really to take what you've learned here today and apply it. Apply it to where you are as a practitioner. In the subject line of that email, just make sure that you put that it's a CEU request for the role of cognitive behavioral therapy and addiction treatment. That way, Carissa will know that this is a request for CEUs. So thank you very much, and we'll hope you'll join us again for another one of our presentations. Thank you.